right?
Yep.
Okay, all right, so we'll start again here. Sorry about that. Hello, everybody, MedLinks members, those in the personal injury med legal space. I'm Dr. Dawn Kyle, and I'm here with Dr. Jennifer Pedley. We are going to be doing a deep dive into soft tissue injuries of the cervical spine, something that I am deeply interested in and always want to learn more. I'm really excited about this, having been a patient myself with the cervical trauma, and it seems to be something that is often not taken deeper in our profession as far as looking at the more subtleties in injury of the cervical spine, mainly in soft tissue spinal injury with low impact auto accidents, tends to be somewhere that a lot of these are missed because they're not super obvious. So this is going to be really exciting to learn more and do a deeper dive in here. And we'll probably do some more ongoing trainings with Dr. Pedley as well. Thank you so much, Dr. Pedley, for being here. And I'm going to let you take it away.
All right. Thank you, Dr. Kyle. Just echoing Dr. Kyle, yes, we're going to dive in a little bit deeper with our radiographs. We're going to be looking at cervical spine, and we're going to see what indicators that is going to tell us or show us soft tissue injury. And these are ways we measure according to the AMA guides. So we're going to go through several different cases. The outline of this is going to be, of course, you may already know about the AMA guides. We follow the fifth edition. There are corrections to that I have included in this presentation. And what we're finding is we're looking for, according to the altered, the the AOMSI, and also with that, there's two areas that we'll be looking at. It's going to be for translation as well as angular motion. Other side ones that we're going to be evaluating is going to be the atlantodental interspace for those widening areas, as well as anterior and posterior disc wedging, which can indicate ligamentous trauma, and lastly, interspinous widening. So most of us are familiar with the AMA guides, the fifth edition. In school, I didn't know what this was. And when you get out into private practice, and also into the PI world, you got to make sure you know everything about the AMA guides. So the two areas that is, according to the AOMSI, is going to be ligamentous instability of the cervical spine being translation of the vertebral body segments on your flexion extension x-rays. If it's greater than 3.5 millimeters, then that is ligamentous instability. And I'm going to show you how to measure for those. Also, angular motion, which is also classified as angular difference. And we're only visualizing this on the flexion lateral x-ray of that cervical spine. And if it's greater than 11 degrees in difference relative to the areas above and below that segment, if it's greater than 11 degrees, then we have ligamentous instability. Other ligament injury that we can see on our x-rays, which we'll go over today, is again, the atlantodental interspace. If it's greater than 3 millimeters in adults, greater than 5 millimeters in children, then it's an indicator of transverse ligament injury. Interspinous widening, if we have increase in distance between spinous process, that could be an indicator of posterior ligament injury. And then lastly, the anterior and posterior disc wedging on your flexion and your extension x-rays. If we're seeing wedging, abnormal wedging, then we're going to be, that's an indicator rather of the injury to the posterior longitudinal ligament and or anterior longitudinal ligament. So we're going to be going through each of these categories and showing some x-rays to go along with this. The AOMSI that we want to focus on again is going to be in the category 4. And that is where we get the whole person impairment, 25 to 28%. And those two areas that we're going to be measuring is the translation motion, which has to be greater than 3.5 millimeters, and then the angular motion difference of greater than 11 degrees. So we'll be showing some examples today. Other possible categories, and the reason why I'm saying possible is because it's going to come back to what is the patient presenting clinically. So this is going to include your clinical examination findings. If it's not in the realm of instability, so it's less than that 11 degrees of angulation, but we see some other signs. It's less than 3.5 millimeters of translation, but we see some other signs of ligament injury. It might be in the category 2 and it's depending on what is the patient presenting with. Okay, I already talked about this. Again, it's just reiterating. The one thing I always get asked is MRI. Isn't MRI going to show this? Most often, no. With the MRI cannot show us tears of ALL and PLL. And some ligaments are a little bit special on MRI. And the reason why I say special is because it doesn't show high signal. And we cannot see those tears on MRI. I have attorneys out there that they kind of go, I really don't need X-ray. But we're losing information in proving that there is ligamentous instability or ligament injury. And the X-rays, the flexion extension X-rays are extremely important. So again, MRI cannot show some of these ligament injuries or tears. Obviously, if we have a lot of edema in the posterior aspect of the soft tissues, that can definitely be an indicator that we have tearing in those specific tissues, but it's not going to show at all on MRI. So this is coming from the AMA guides, and I know this looks like a lumbar spine, but the way we measure for translation is exactly the same, whether you're in the cervical spine or thoracic spine. Typically, we don't have anterothesis or retrothesis of the thoracic spine because of the rib cage, but obviously, maybe a T12, we could see those areas that might have some translation. So this is showing that the line is going to be, you're always comparing to the level below, excuse me. So let's just say this is L4, comparing it to your L5. That's what it looks like here on this lateral image. And we want to look at the posterior aspect of those vertebral bodies, and we're comparing it to the level below. We do have to be careful about measuring from corner to corner because some individuals might have a posterior osteophyte or this normal ridging, and it might look like there's retrothesis of a segment, and whether there really isn't. And it actually will devalue the amount of anterothesis. So we want to concentrate on that George's line or posterior vertebral body line. And I'll draw that line down, which I'm going to show you an example on my x-rays of what I do. And then we would compare to the level below and how much that segment has gone anteriorly with your flexion views. And then with your extension, is it going anteriorly or is it going posteriorly with that translation? And then we would add those values together. So again, if it's greater than 3.5 millimeters, that is an indicator of instability. And this is according to the AMA guides.
Question.
Yes.
What is the most common mistakes do you see that those practitioners that try to do these measurements and diagnostics on their own that are not certified at your level? What do you see
Yes.
commonly?
One thing I do see is they use percentages. They'll just say, oh, there's a 10%, antrothesis or 5%, and that doesn't help us. Or they just guess. They go, oh, that's about 2 millimeters. Anytime I see like it's just 2 millimeters, 3 millimeters, and it's like 2.0, I kind of question whether or not they really measured at
Mhm.
all.
Right.
Um, and I
Yeah.
see that a lot, even on MR. It's just kind of like, oh, it's about 2, it's about 3.
And
Um,
yeah, wouldn't you agree too that the human eye cannot see a lot of this? You miss too much, especially for those that are just eyeballing it.
they
Um,
do,
you,
absolutely.
yeah, and so what have you seen like significant, like even like a maybe possible impairment rating difference if they're trying to eyeball this or do it the old school way without having technology? What have you
Right.
seen it like actually bump them down a category that the patient could have actually been an impairment?
Yes.
Yeah, I've
Yeah,
seen that too.
absolutely.
Yeah. Okay.
They'll just
That's very
state, oh,
important. Yeah.
yeah, they'll just say, oh, there's antrothesis and it reduces on this, on the extension, but it's very vague. There's no numbers, there's no measurement, there's nothing. Or since they don't measure all the time, they're missing like, for an example, they're going to miss a 1.6 millimeter translation going anteriorly. And then they've got, 1.8 millimeter retrothesis with extension. Well, if you add that together, you're already in the 3.5 millimeter. And yeah, it might individually look, subtle or mild with flexion, but when you add those values together, it's huge. And that's what I see most often is they just kind of go, there's a little bit of this and mild this, and they don't use the measurements. Also, they don't know how to measure it when they do try to measure it. And again, that's why I'm, pointing out here with this diagram is
Yeah.
you have to look at the posterior margin and draw your George's line down. And
Mhm.
then you compare it to the level below. You're not comparing it to the level above, and you're comparing it to the level below. And then you're going to have that line coming down through the posterior margin. It's going to traverse through an osteophyte. So we don't want to include an osteophyte within that, which some of them would. They'll just go right from that posterior aspect of that corner, which has a large osteophyte, and it definitely devalues the case.
Yeah, and I want to make that point too that when you're in personal injury, you're in the med legal space. At any time, you could end up having to be deposed, go to trial, and the last thing you want to do is look incompetent because you wanted to mark these yourself. I think that the time of a doctor trying to be everything, do everything has long been over. And if you want to be at the level of the orthopedics, the MDs, I don't know any neurosurgeons that do their own markings personally in their own. I mean, it's chiropractors should stop that behavior, in my opinion, and should start using your services and services like yours because it's so critical to the patient and it's so critical to the case that this is done properly and right. And the other part of it is having a objective evidence opinion from a third party is so powerful with someone with your credentials. So I'm just going to throw that in there. When I do my coaching with chiros, I'm always like, this is the way you want to do it if you want to be in PI. So you just exactly pointed out one of the common problems that we see.
Yes,
Continue, please.
absolutely.
All right.
Yes. And even in this diagram too, I could go even more in depth of this segment. We have anterior disc wedging and splaying apart the spinous process, which we're going to talk about next. But sometimes there are combinations going on at the same time, and we have to put all the pieces of the puzzle together. That is not going to happen with some of these generalized radiology reports. They're
No.
not able to put all those together and say, hey, because of all these three things, now we're dealing with this. We're dealing with an instability case, or ligament injury and so forth. And then that's going to be correlated then by the doc saying, yes, all their pain is right in that region.
Right. Correlating the symptoms and other evidence-based documentation. Absolutely.
Yeah, absolutely. Yep. So the next one, this is our case here. So we have
Yep.
an AP and lateral views, and these are the neutrals, right? The neutral lateral showing degenerative changes and so forth in the posture. Um, a normal ADI on this one as well. And here is your flexion extension. And then I'm going to take it piece by piece, in with the drawing of the lines, for the purposes of this segment. So with the C3, and if I want, I can back up. We're going to talk about C3. And C3 is kind of our culprit. I'll just kind of give you a heads up. And then now we're going to look at C3. So I just kind of magnified this view, showing how we would measure this. I'm comparing C3 to the level below. And then this is what of our measurement for anterothesis, or that translation that has gone anteriorly, is about 2.9 millimeters. And with the extension is going to be 1.6 millimeters. So as you can see here, if we add those values up, is going to be greater than 3.5 millimeters. And
Mhm.
sometimes to some radiologists, they just kind of eyeball this and like, oh, just a little bit of wiggle, it's just kind of a little bit going backwards and going a little bit forward. But when you actually sit down and draw these lines, you're like, oh, whoa, wait, this is something. There is
Yeah.
something here. So this is 4.5 millimeters.
Uh-huh.
Absolutely ligamentous
Yeah.
instability
Mhm.
of C3.
Yeah, absolutely. And this is where the patients we often see, and I hear this from attorneys as well, as like my patient had 2 years worth of care and they're still having these symptoms because it wasn't diagnosed as the true injury that's permanent. And how would you then, do your clinical treatments, right? Based on that. So
Right.
you can't miss these things, guys, especially in the space that we're in as chiropractors. I mean, this is what we see all day, every day, low impact soft tissue spinal injuries that are coming in, and you can't miss these things. These are so important.
Absolutely. Absolutely. So at the level of C2 and at C4, I have included these as well. So at C2 is anterothesis only at with a flexion of 1.4 millimeters only. An extension, it looked normal. At C4, we have abnormal anterothesis of 2.8 millimeter. So again, and that was on flexion only. So these are not being greater than 3.5 millimeters.
Mhm.
So they are in the category of ligamentous laxity because there has been overstretching of these ligaments. They may have some pain in those regions, maybe not. But again, it goes back to what are the clinical findings and if they can be rateable, maybe at a lower grade, not of the category 4 that we saw at C3, but
Right.
maybe at, category 1 and 2. It's better than nothing, but it shows that there is ligament injury for this patient.
Absolutely. Absolutely. Yeah. And people have to remember too that you have to take these segments independently of each other. A lot of people think, oh, it's the whole neck, the whole, it's like, no, C3 is AMSI, but the other
Yeah,
two regions are laxity that, the story comes together, right? So don't
right.
overlook the fact that each motion segment has its own rating and individually put those
Yeah,
together and when you're making your reports.
absolutely. Absolutely. So this is just a rundown of what we just found here of each level. So there was some very minimal amount of motion of retrothesis of C5 and C6. I couldn't even quite even get a measurement. It was like 0.07 millimeters. So
Mhm.
that one we have to say could be due to degenerative changes, or it could be normal physiologic motion. Because if it's less than anything that's kind of less than 1.0, I'm just kind of like, this could be just their normal little wiggle room. I have some docs who are like, oh, that's where they have their pain at. Well, I'm not saying they don't have soft tissue pain,
Right,
but with the flexion extension, we're just not seeing that translation.
right. Makes sense.
Yeah.
And when you've seen thousands of these views by now, right? Like you've seen,
Yes.
do you see a common trend where C3, C4 is getting the
Mm.
bulk of this instability? And I mean, is that kind of a thing that you've seen on low impact injuries in general?
Yes, it's actually between three segments. The C3, C4, and C5 are
Right.
usually the most top, ones. Um, I see more degenerative changes at C5,
Hmm.
and sometimes with the degenerative changes, it will try to stabilize that area.
Hmm.
That's probably chronic, maybe from some other traumatic event, or that's just their normal degenerative change.
Right.
But yes, more of the C3s and C4s, absolutely. C2, not a lot.
Hmm.
But I do see more of the C3, 4, and 5.
Would you see typically a little bit more of C1? And I don't know if we're doing ALAR in this
I
one.
didn't include alar ligament. I
Do
definitely
that.
could on the next
We'll do
next
another
time
one
we
on
do
that.
this.
Yeah.
Yes,
You
yeah.
say that's because if there's a slight rotation during impact, are we going to see more? But we'll save that for our next one. So
Yeah.
I think the take home for clinical providers here is, it's not just the neck walking in the door when you see them. They have degenerative changes that could be causing symptoms, but you got to diagnose what was injured in this accident. That's what we need to know. How do we rate this for this particular accident, and how does the pre-existing of the degenerative changes affect this, right? So there's the eggshell
Absolutely.
effect. So all
Yes.
these things coming together when you're getting these reports and you're looking at this and you're seeing your patient and you're putting this all together, the more and more that you work with Dr. Pedley and understand these subtleties and she can educate you on this, the faster and the more efficient you're going to be with your treatment plans. And even when you are figuring out how to explain what is actually, going on with this patient from an evidence base. So I suggest you send all of your studies to her.
Thank you.
So you can learn, even it's just to learn more, right? To
It
learn more
is.
about
No,
this.
and you do. I've
Yeah.
heard that a lot from my clients. They're like, wow, I've learned so much since I've been using your services, or I would have completely overlooked that, or I
Yeah,
never would have thought of, X, Y, and Z.
absolutely.
I do get that quite often.
I figured you would because I feel that way. So
Yeah.
we've got common areas that we see, which makes sense with mechanism of injury, the whiplash effect for CAD injury, that middle region would be taking the bulk of that movement. If it's just a straight, rear end collision or maybe a front end collision, but you get rotation and things in there, you're going to start. When you see rotational injuries, do you see more of those in the upper cervical, or do you see more injury?
Mhm.
What kind of things would you see more if someone had a rotational component to this?
Yeah, the rotational kind of echoing back to what you were going to talk about with alar ligament. I do
Hmm.
see more, and not always, but,
Hmm.
sometimes I do see more upper cervical spine involvement. And in particular, we see that with alar ligament because alar ligament, you get a side impact,
Yeah.
and then you whiplash off laterally, correct? So then when you go to, let's say if you're bending to the right, it's the left alar ligament just trying to hold on, and then it gets torn.
Right.
And so then when we see on these AP open mouth views with right and left lateral bending, then we can see lateral mass bypassing the margin of C2. And then we know there's alar ligament injury. So we do, and also clinically, right, when we're palpating our patient, they do have a lot more sensitivity, hypertonicity, inflammation, particularly in the suboccipital regions. And around C1 and C2, they are in a lot of pain when we have more of a combination of rotation and lateral bending type of mechanism of injury.
Yeah, yeah, absolutely. I can't wait to do that one with you too.
Yeah.
So, okay, got this. Challenge
Yeah,
rotation.
challenges in when taking
Yeah.
x-rays. And I know some
Yes.
docs may not be taking their own. They might be sent to an imaging center. But this is where it's kind of my like, oh, I wish they weren't rotated. So on this lateral view, this is just a now lateral neutral. You can see both sides of the mandible. So you can see the posterior margin of the mandible as well as the bottom portion of the mandible. So sometimes that can make a segment look a little bit more antrothesis or retrothesis.
Hmm.
And so I always encourage docs to make sure you're positioning your patient, look at the patient, make sure they're not rotated. I know that might be their normal stance is in rotation, but when we go and we flex and extend them, it's if I get a lot of rotation in there, then I'm not going to get a true value of that translation of that segment. And it can
Yeah.
be challenging because some individuals, some of your patients are going to be, they've got muscle spasms, they're having a really hard time flexing, extending anyway, which leads into if your patient can't flex and extend the cervical spine, it's okay to take those first set of x-rays because it shows they can't flex and extend. But then you're going to have to repeat those x-rays later on when they can flex and extend the cervical spine. So then we
Right.
can really see are those ligaments intact or are they not?
Right. Would you say that, I mean, initial x-rays, are to rule out more like fractures and things like, and if they need MRI and that, whereas, but you're really going to get this ligament diagnosis, like how long would you say after the acute phase that you get the most out of seeing, or the earliest stage that you think they should do that repeat x-ray to really see that motion?
Yes. I mean, it's going to be per patient basis. During your clinical or your examination and you're having them going through the ranges, if they can flex and extend, then go ahead and take the flexion extension.
Mhm.
If they just cannot move, then you're going to have to, obviously, your treatment is going to be focused on decreasing inflammation
Mhm.
and getting the hypertonicity to calm down and so forth. And then slowly, when you're seeing that, okay, now they can flex and extend. Now that is a good time. Usually that might take a month,
Yeah.
because you're trying to combat the inflammation. That's the number one thing with these whiplash, patients.
And they may be dealing with other things too, TBI, a lot of things going on,
Absolutely, absolutely.
Yeah.
But take your standard views first, meaning take your AP and lateral and EP open mouth, making
Yeah.
sure that there are no obvious fractures
Right.
and also contraindication to your treatment.
Right.
And
Exactly.
then, yeah, then do we need a referral for MR? With PI, yes, you do eventually. Within my recommendation is MRI within 1 to 3 months of their accident.
Hmm.
After 3 months, all that edema and stuff is going to go away because the patient's healing. And we can't then see the severity of the initial injury.
Right.
But in the meantime, yes, we do need to do our x-rays. That is part of our standard or primary examination.
And do you have x-rays that come to you without this marking over here, like the left and this little circle with can you explain a little bit more what the value of that circle with the little dots in there is
Oh, yes,
there?
yes. So this is indicating that the patient is standing. As the little dots were more, in the middle and superior within that little circle, that means that they're lying down. So
Okay.
they are weight bearing. So we want our x-rays to be weight bearing.
Yep.
to show, particularly when we flex and extend, because that's what we are. We are weight-bearing creatures. And so we want to stress the spine in an upright position as well. And the left is because they put a left here. A lot of times I don't see on the lateral images, which to me, that's not a big deal.
Mhm.
But they're using left because the left side is against the panel or the bucky.
Got
And
it.
but we do need to see those on the AP views, and particularly for medical legal cases. We're supposed to anyway have patient
Right.
identification as
Yeah.
well as laterality markers. So that way it can't be argued like, oh, what side is that?
Right. Exactly.
Right.
Use your
So
markers. Yeah, use your markers.
yes.
So, okay, great. Excellent.
Different case, I just kind of quickly put in my measurements. Of course, I had already, because I used a different program for this. And
Mhm.
again, just for simplicity of today for this
Sure.
lecture. So with a C3 is showing you another example of C3 showing some increased in motion, and 4 millimeters would add up in total. C2 did have more of the extension. Some people might argue like, well, isn't there a little bit on flexion? Eh, I don't, that one, I was just like, it's like less than 1.0 millimeter. It's no.
Go with
And
the measurement. Yeah.
yeah, I was just like, I could barely even get anything.
Mhm.
And then C4 is on the verge, right? And that's something that I will even remeasure because I'm like, oh, 3.4. What if I measured incorrectly? So I
Right.
always remeasure if I'm right on the border. But it was consistent at 3.4 millimeters. I know it's just under our value, the instability. And then at 5 at 2 millimeters. So ligaments instability is going to be then at the level again, C3. I didn't even mean to do that, but having the second case here.
And have you seen also differences with male and female when you
Hmm.
go through these, as far as are you seeing any more increase on ligament damage with female patients versus male patients, just because you've seen such a volume of these X-rays?
To be honest, I have not. That's just my personal
Mhm.
opinion and in my practice. I haven't seen a lot. I know technically we probably should. And then it has to do, of course, the cervical spine doesn't have a lot of muscle mass to stabilize the area. Um, and you would think technically, male patients would be able to stabilize maybe the cervical spine easier because they have more muscle mass. But that's not always true, right? We have a lot of women too who have got muscle mass as well. So I'm
Yeah.
not saying that. It's just that I have not seen a huge difference where I'm like, oh, this is not gonna hardly have anything because they're male, or they're gonna have a lot because they're female. I'm not
Yeah.
really seeing that. But however, age, like if I have a younger patient, 25 years of younger than 25, that can get to be a challenge because individuals who are not skeletally mature, so skeletal mature means at age 25 and above, so
Mhm.
anything less than that, they can have this normal laxity of their cervical spine, which brings a challenge. And it comes down to, I still measure, but it can be age-related laxity. But if I
Mhm.
see a lot of motion going on here, then I'm going to state, okay, this is most likely instability, clinically correlate for symptoms of this region. And if
Mhm.
I have anything else I can see on these x-rays that can back up ligamentous injury or instability, I will do so. But young patients are challenging.
Yeah, I can imagine that. And I think this just lends to show people how important these ligaments are and how strong they are, that a male and a female, you think the muscles and all of that, conditioning would be protective, but truthfully it's the ligaments that are protecting the joint motion at the end of the day. Because if you're not seeing a dramatic difference in the same car, and it's proportioned to the weight of the head of the male and the female. So there's a lot of physics involved, but just shows us more and more how important all these, ligaments are, and how you have to really understand the building blocks that they provide for our entire structure. And
Absolutely.
I have a love of ligaments, if you haven't noticed. Anyway,
We like our ligaments to be intact.
yeah, we like them to be intact and do their job. Uh,
Yes, absolutely.
Interesting. Okay, good to know. Good to know.
Yeah. And on these x-rays I showed here, the atlantodental interspace, they have been all normal. Uh, if we see widening, typically would see increased widening with the flexion because that is a stress radiograph for that particular region. So in these x-rays that I have shown so far, the
Mhm.
atlantogental interspace have been normal.
Okay, gotcha. One
All
thing
right.
I
So
know here that I've seen on some that I don't see on others, if we go just back to that one slide,
yeah.
is I had a question about that. You see up here, this looks to me, like a more like a female spine to me, just from the view, but I could be wrong. But you see how the on extension you have the occiput, touching here, and
Yes.
it's not like that on everybody. Some people have that. What's your note on that? And the reason why I bring that up is because it's often not commented on. And I was watching a surgeon in Florida who does his specifically on these type of injuries, ligament injuries, and he uses PRP and he uses all these different. He's a surgeon, and he talks about this causing symptoms. Any thoughts on that? I know we weren't addressing that, but I just happened
Yeah, no, it's
to.
great. No, it's great. With this one, a couple things. When we do have proximity of the occiput to C1, it can create what we call impingement. Just like anything, if anything comes too close to another bone,
Mhm.
that's not typically supposed to be there, then we call that more of impingement type of mechanism. And then we have technique specific docs out there too. And they will measure this and tell me if this is extension, posterior orientation of occiput, extension of the upper cervical spine, or lack of motion of particularly the C1. So there is a lot of technique specific individuals out there, which is awesome. And then also with this is we have to be careful that because they are in lateral flexion, it's going to mimic sometimes the appearance that the occiput is actually contacting C1, but
Mhm.
it's still close though. I absolutely agree with you that it's approximating and that's not typical. So there could be if you as you can see in this extension, all
Mhm.
this motion is happening at C3, C4,
Right.
right? And
Mhm.
so it's just kind of like trying to get back there, and then maybe occiput is going a little bit further because it can.
Yeah,
And
exactly.
right, and
Yeah.
the upper cervical spine's like, oh, well, this is as far as I can go. And then all that motion now is all occiput.
Yeah.
And
Yeah.
everyone's different. So that's another scenario too, right?
Yeah.
So then we have to look at, okay, what's restricted when we're palpating our patient?
Mhm.
Where is the pain? Where is it restricted? Does this make sense to what you're palpating and with your examination findings?
Yeah. Interesting. I love this.
All right. So now we're going into another instability category. So angular motion. So there was a correction on the AMA guides, and you're only using flexion, your lateral flexion X-ray of your cervical spine, and you're going to be comparing it to the adjacent levels above and below. And then you get is the difference of the measurements. If it's greater than 11 degrees in difference, then we have ligamentous instability. And it can be either neighboring a segment or it could be both. So if one segment below it is normal and the other one above the one that we're questioning is abnormal, that is still instability. It doesn't have to be both segments above and below the area. So I'll show you. I know it's kind of hard to talk about, but I will show you an example. So I'm gonna go back. I'm gonna come back to this in a second. Sorry, let me go to this diagram. So the
Mhm.
diagram is so we know that this area here, this segment here, let's just call this C5. So this C5 is the area that we see there's actual angulation going on. It's the apex of the angulation. So if I want to know, okay, is this segment stable or unstable? Then we compare to the level above it. So we draw this line along the end plate above it. So if this is C5, this will be C4, and then we get that measurement angulation. And then we have to compare it to C6 and then C6 to C7. So we have to compare two levels below and then one level above. And then with the C5 to C6, we get that angulation. And then we got to make sure, okay, if we compare it to this one, what is that angulation? And then this is the calculating the difference. So this is what I'm going to show you on X-ray of when we're following this type of diagram. And this is according to the AMA guides. So an example would be that if we had C5, C6, if we had this diagram and it went at C4, C5, it measured 8 degrees. At C5, C6, it measured 22 degrees. but at C6, C7, it measured 9 degrees. Then we subtract. We subtract the one above it, subtract the level above it. If either one of those values are greater than 11 degrees, now we have ligamentous instability. And it's because of the angular motion. And again, this is only on the flexion X-ray. At one point in time, they were stating that was going to be on flexion and extension, but that was the correction that was made for the
Got it.
AMA guides.
So just flexion view for
Flexion
angulation.
view.
Okay.
Yep.
And
Yep.
do you provide this measurement different? Do you do this in your report, the math on this?
I do.
Oh,
Yes, I
okay.
do. Even with the translation too,
Mhm,
I
mhm.
will state, how much antrothesis, retrothesis, resulting in total translation of, let's just say 3.6 millimeter. And then after I get done with all my measurements, I do put a caveat in there, like anything that is greater than 3.5 millimeters
Mhm.
indicates ligamentous instability. Even with this one here too, angular motion, I will reinstate, according to the AMA guides, instability is greater than 11 degree indifference of the adjacent levels. So I reinstate that because I never know where my report is going sometimes. Is it the
Right.
attorney that's
Yeah.
reading this?
Hmm.
Of course, I'm hoping it's our chiropractors out there, but then if that report then goes to an attorney, at least they
Right.
can read it, they can see it, and it also educates them too.
I think that's helpful for any busy doctor, anybody busy. You just want to get to the cliff notes,
Absolutely.
and see what's important and then go back and digest the information. So, okay,
Yeah.
great. Have that
Yeah.
in the report
Yeah.
for.
In the impressions, it just states it. In my
Yeah.
impressions in my report, it'll just say instability at C3. And then you can see above the description and how we got there and the terminology, and if there's anything else going on in that area. But in the impressions is like a summation of everything. It's just a
Yeah.
generalized comment of a diagnosis of what's going on. If you need the detail, then you have to look into the report, of course.
Yep. Okay.
All right, so this is again just showing measurement of angulation here. So if we are comparing, you can see that the C5, C6 area might be the area we're concerned, but I was also concerned about C4, or
Mhm.
excuse me, C3 and there's C4. It looks like C4 is kind of the apex of your angulation here. So we're going to compare it to the level above it. So at C3, C4, comparing it to C4, we are going to see 3 degrees. So from here and drawing your line along the inferior end plate, so you're comparing it to the level below, and we have 3 degrees at this region. And then so there's 2, 3, 4 at C4, C5. I don't know if you can see my arrow or not,
Yeah,
but
we
at
can see
C4,
now.
C5, then we have that angulation of 6 degrees. Then at C5, C6, we have angulation of 12 degrees. And then we go into C6, C7 is 10 degrees. Now, what does this all mean? If I want to find angular motion at the C4 level, so remember 2, 3, 4, this is your C4. If we want to see angular motion, then we go to the level above. So that's 6 minus 3 degrees. And then we get, of course, 3 degrees. That's not greater than 11 degrees. So that means there's no instability at that region.
Hmm.
Also, if we go from 12, if we were to compare the C4, C5 disc, at that level to the C5, C6, then we end up subtracting 12 minus 6, and that is only 6 degrees.
Right.
So we do not have instability at that area. Now, if we're looking at the angular motion at C5, C6 area, again, we're comparing to the level above, level below, and then it's not greater than 11 degrees.
Hmm.
So with this one, and I know it looks, more exaggerated, when you see these, but when you go down and you're measuring it, you're like, oh, we're not greater than 11 degrees. Doesn't mean they don't have ligamentous trauma or injury. It's just not in the category of instability.
Right. Right. Exactly. And that's why we measure, right? We
Yes, absolutely.
measure.
We're not guessing.
We're not
We're not,
guessing.
we're not
Yeah.
guessing.
Yeah. Not
Yes.
on the patient's, I always tell people like it could be your thousands PI case, but it's that one patient's one injury. To them, it's their injury, their one, maybe two in a lifetime. So
Yes.
not
It's
gonna
their
guess on
livelihood.
anybody.
Yeah.
Right. Yeah, exactly.
Yeah. All right. Other things that we'll be looking at is the atlantodental interspace on the lateral. disc wedging, and interspinous widening. These are just kind of indicators that there's some other things going on here for ligamentous injury. The atlantodental interspace, we've learned about this in school so much.
Mhm.
Talking about widening, and when we see widening, it could be then injury to the transverse ligament. So if it's greater than 3 in adults, greater than 5 in children, and again, skeletal mature happens at age 25, and of course, more. We're skeletal mature after that.
Mhm.
So with that, we have to then look at the flexion x-rays and extension x-rays as well. But if we do see increased widening, typically it's on the flexion x-ray. So it can be on the neutral lateral being wide and or flexion.
Gotcha.
One point to make out that I want to make out here and stress so much. If you can see here, jewelry is overlying the area. No
Yeah.
matter like these hoops, they're always overlying the dents. Always. I'm like, please remove jewelry if they can. It's
Yeah.
so helpful. Otherwise, I can't rule out a dens fracture or any abnormality in the area or even to measure. It's just very, very frustrating. So
Absolutely. Well,
remove
yeah.
jewelry.
Remove the jewelry, all the earrings, everything goes. Yes.
Yes. This was a case that came across my desk, and with the challenge of sometimes the atlantodental interspace is it may take on what's called a V-shaped, V is
Mhm.
in Victor. So
I
a
see.
V-shaped atlantodental interspace. Just because it's V-shaped doesn't mean there's ligamentous instability or laxity. Some individuals just have that's their normal shape. But in
Mhm.
this case, it was definitely wide. And I had to take 3 measurements and get an average because I was like, this looks really wide to
Mhm.
me. Usually when I see a V shape, it kind of closes down inferiorly, but
Mhm.
this one just looked more than I've ever seen. So what I do is I take 3 measurements, kind of more towards the superior, not the very top, but kind of near it, the middle and slightly inferior, and then take an average, and it was averaging 3.6 millimeters. So that is a sign of instability, particularly of the transverse ligament.
Mhm. I see that very clearly at the bottom. It's wider than
Yes.
a typical
Yep.
E, like you said, more of a sharp point at the bottom that
Yep.
you would notice.
Yes. Yeah. It doesn't close down. Usually it typically would. If it was a normal V shape, I would see the border come through here a little bit tighter. And
Yeah.
it's like, oh, that's normal. But this, it's all opening up.
Yeah, I see that. Good thing to look for.
Yes. All right, we kind of talked about that. What does the transverse, ligament actually do? It holds a couple things. It holds the dens and the C1. So it prevents posterior displacement of the dens because, the ring is just going to be moving, and then prevents anterior translation of C1. So when we do have tearings of the transverse ligament, then C1 is going to go for a ride. It's going to go anteriorly. And then that's why we have this increased distance on our lateral x-rays. Then we get into disc wedging. So when we look on, we need the flexion and the extension x-rays to then see if there is wedging of the disc. So when we do have posterior disc wedging, that means the posterior aspect of that disc height is decreased and the anterior aspect of the disc is increased. So that is what we call a posterior disc wedging. So that puts more stress on the anterior ligaments. And
Mhm.
then it's the reverse. So for anterior disc wedging, it's closed down anteriorly, but widens posteriorly of that disc face. And that's going to put more stress then on the posterior ligaments.
Mhm.
So what this is, I was trying to, draw the lines for everyone to see that you can see that there is, particularly between C3 and C4, we do have, it does look very subtle, but we have posterior disc wedging when that patient went into extension, as well as, you can see translation too. You can see the posterior or retrolacesis of C3 when they go into extension. This is our same patient. So the same patient that we saw, you see the occiput to
Mhm.
C1, that's that
Yep.
approximation net. So
Mhm.
this is our same patient that we had that we saw instability of C3. And then also at, so there's 2, 3, and 4 at C4, C5, we still see that posterior disc wedging. So that is telling me that there is injury to the anterior longitudinal ligament.
Mhm.
And when they go into extension, it's going to stress those areas, and that's why it's opening up. Typically, when someone has an intact, no trauma to these ligaments, when they go into extension, they don't get wedging. It just the whole, you see just this smooth transition of the discs just keep their normal height. But with injury, trauma to to these ligaments, then you're going to see some increased widening. When they
Yeah.
went into flexion, I'm not seeing any anterior disc wedging at the C3, C4 disc level, but at C4, C5, I do, C5, C6, and more mild at C6, C7.
Mhm.
That is indicating to me that there is some trauma or injury that has happened to then the posterior or longitudinal ligament or posterior ligaments. Now, with this, if I do see increased distance of the spinous process, which I do not here, I
Mhm.
also look at the facet joints, making sure there's no gapping or perch facet. If I do, then I absolutely am, I'm going to hone in on my report, and I'm going to be talking a lot about there's injury to the interspinous ligament, there's injury to the facet capsule, there's this, there's translation, there's anterior disc wedging. All of that together is telling you there is ligamentous instability.
Absolutely. Definitely would have symptoms with that.
Absolutely. I found this diagram and I have listed my reference here as well, but this was a great diagram just kind of illustrating widening of the posterior aspect, the top picture of the widening of the posterior of the disc. So that is considered as anterior disc wedging. And we have anterior disc wedging. Again, you're putting more stress. And even with that, you might have anterothesis with it at the same time. Increased stress on the posterior longitudinal ligament. And then the other diagrams are showing where if you have a retrothesis and you might also have posterior disc wedging, meaning the anterior aspect of the disc is opened up, then you're placing stress and injury then to the anterior longitudinal ligament.
I love this view. I actually have this in my reports in the site in the section of just citations, and
Yes,
this is just good to have to educate attorneys, medical doctors that don't live in this space. They can see this so quickly visually, and it just makes sense. I would hope
absolutely.
that somebody would come up with, and this might be a thing for you, Dr. Pedley, is a 3D model, of this that
Oh, that'd be
have the
great,
ones
right?
with the disc and degeneration. This would be so great to also have to explain this to patients because they don't know, they can't visualize this. Very difficult. I mean, I guess you could use it, but this somebody needs to come up with a 3D model of these if it doesn't out there already. But I love this view that you found. Yeah, this is
Yep, this is
visual
great.
always explains it so much easier to people.
Yes, absolutely. And I like this too because particularly for attorneys too, they may not know the anatomy. Maybe they do, I don't know. Some of them
Mhm.
might be kind of fresh into PI and not knowing what the anatomy looks like. And when we're talking about certain things on the x-rays, this is showing ligamentous injury, even though, yes, we cannot actually see the ligament on the x-ray. So that is the comment I get as well as, again, as I mentioned earlier, is the MRI. You would think it would show tearing of ALL and PLL or some of these
Mhm.
other fine ligaments, but it just can't. Our MRI scans are not thin enough slices. And sometimes some of these ligaments, when they get torn, they don't show high signal. They just show disrupted fibers or they just look more attenuated, which means more black, more thin. And they're just, that's like more of the partial tearing kind of category. But we cannot see that on MRI.
And considering a lot of, what is it, something like 70% of injury cases that are going to an attorney's office happen to be low impact auto injury, typical or slip and falls that are not super traumatic and ringing the bell, but people are suffering. It
Absolutely.
causes major suffering in people long term and the degenerative changes. So it's very important to really dive into this and understand it and be able to articulate to an adjuster, to a jury, why this is so important. So the more that you can learn about this, the better you're going to be able to serve your clients with these abundance of cases that we get in this category, right? Like
Yeah,
this is kind of more of the typical injuries you see in those injury cases. So this is great for doctors and attorneys, of course. Med legal
absolutely.
completely. Yeah.
Yeah, and it backs up what the chiropractor is backing up their
Mhm.
treatment protocol and educating the patient like, hey, this is going to take a little time because
Yeah.
you have this. And then they're like, oh, okay, we're not making it up. You have injury and we can prove it. Here it is. Here is the data. And this will just back up more and more of what the chiropractor is trying to do for that patient, as well as if it goes into a medical legal case then having that conversation, with the jury, I guess you call it conversation, but presentation with the
Yeah,
jury
yeah.
or the judge, whomever. So yeah.
Yeah, and it's I think it's as we move into the world of AI and as we know on the back end insurance companies, private pay insurance, also of course, Colossus and all those injury softwares, they're bringing AI in. And if you're not producing evidence for the things that you're doing in a way that is way past circa 1995, you're going to get audited, right? You're going to get
Yeah.
audited. They're going to look into you and you're going to get red flags. So it's very important that you showcase these, send these to the adjusters, educate them so it doesn't move up the chain, right? That you're not giving them evidence base. And they're going to, at the end of the day, the insurance companies, they just want you to show them what's the injury, prove it. I'll pay
Yeah.
it, prove it. Just let me know. But if you can't show it, articulate it, and have evidence, especially accepted with the AMA guidelines and medically accepted diagnostics, then you're just shortchanging the patient, in my opinion, at the end of the day, because they can't fight for themselves. They don't know how to articulate this to an adjuster. So
Right.
it's
Definitely.
very important to really understand this and spend time getting back into learning, and really getting yourself educated. And you do such a great way of sharing this. So I hope a lot of people have learned just on this presentation alone, if not a refresher and reminder how important these injuries are to find.
Absolutely. Absolutely. No, great point. With the next one, this is our last category. So interspinous widening, and why do we really care about it? This is a great case showing, well, we have some compression fractures of the lower cervical spine. And typically, if I do see compression fractures, they are usually in the lower because of hyperflexion. It just crunches down on the vertebral bodies. The areas that might see a corner fracture is going to be the upper cervical spine, particularly like at the corners of C2 and C3, because when they go into hyperextension, then they're avulsing corners of the bone. So the disc material, the annulus fibrosus is attaching to the corner, and then it avulses some of the could avulse the vertebral body. So anyway, so in this one, because I can see that it makes sense they had hyperflexion type of mechanism of injury, and we have because of the compression fractures, but also we have widening in between these two spinous process. And if you're thinking, well, is it really there? Then you look on your AP view, and if your AP X-ray is done appropriately, meaning your AP lower cervical spine should have a 15-degree cephalad tube tilt. If you've done that, then you can see that there is increased distance between the spinous process, even on the AP radiograph.
Yeah, you
Of
see that.
course, yeah, and of course you want to, go ahead and do flexion extension if it's okay for that patient to flex and extend because they have compression fractures here. You may have to wait a little bit. And then we can see if there's any increase in the distance. So that is an indicator of injury, trauma, tearing of the interspinous ligament. Most often when the MRI would show tearing of interspinous ligament, most often. But again, sometimes these low impact injuries, it may not show up or it may not, sometimes it's skipped. Or again, the MRI, I'm hoping they did a sequence called a stir sequence. If they didn't do a stir sequence, sometimes that doesn't show that we can't see the edema, whether it's in the bone or in the soft tissue. So that's a different lecture we can do about
Yeah,
MRI.
yeah.
But anyway, so there's all these different types of posterior ligaments that could potentially get torn, particularly with hyperflexion type of mechanism of injury. So interspinous ligament is what we're kind of referring to here. But
Mhm.
the supraspinous ligament is also called the nuchal ligament. That's where nuchal bones are in. So the nuchal ligament it takes a lot of force, but it can happen. I've seen it only a couple of times, but it just definitely can. The ligament flavum is the ligament that is anterior to the lamina. It's in the canal, but it's anterior to the lamina.
Mhm.
That is potentially that could be torn. Facet capsule. Facet capsule, we cannot see tears of the facet capsule on MR, but what we can, it comes back down to your clinical diagnosis, your
Mhm.
clinical examination, and do we have here on our X-ray signs that there could be some damage or injury to the facet joint itself. At times with MRI, I can see marrow edema adjacent to the facet joints. I've seen a lot of radiologists miss that and they don't indicate that because, well, what are you going to do about that? You don't need surgery because of the edema. But
Right.
again, if that MD or other radiologists are not in the PI world,
Mhm.
then they may not mention edema adjacent to facet joints.
Yeah, which
So
is very painful. Set joint,
very, very
yeah,
painful.
lots
Yeah.
of symptoms. Well,
Yeah.
well, this has been fantastic. I mean, just a great refresher and reminding us, and those of you, like you said, that are newer or just kind of getting into this or haven't really done a deep dive in this, we're going to do a series of these. There's so much to learn, and Dr. Pedley also lectures around at different events. If you ever get a chance to see her live, I definitely highly recommend it. And thank you so much for this. This is really powerful learning for us. We have to constantly remind ourselves that these are going on with all of our patients, not just injury patients. You should be looking at your patients that come in and see if they have any old standing instability as well that could be causing their chronic problems. So it's not always just injury related, although that kind of forces us to get going. Any parting thoughts on this particular lecture?
Not so much. I guess it's just, I run into chiropractors who are too afraid to take x-rays or to repeat x-rays. And with trauma, sometimes we have to repeat x-rays because things change, as well as patients come from the ER, urgent care, and they said that they're normal. You need to repeat x-rays. You need to take x-rays. I've seen way too many times where something was missed or we just couldn't see it yet. And, usually they're coming to your office 2 weeks after the accident. And now we see fractures and now we see instability and we see dislocations. And you would never think they would walk into your office, but don't be afraid. Just to reorder x-rays, take out your x-rays and evaluate your x-rays. Look at them.
Yeah, look at them. You have to train your brain to see.
Yes.
And one question on that, what do you think is the problem with hesitancy to do the appropriate x-rays, repeated views, and do them again, even if they went to a general practitioner who didn't maybe get the APOM view or whatever? I've sent patients back in for many things that weren't that. I mean, you can't see into the spine. You have to do these things for proper diagnostics, right? So what do you think the
Yeah.
hesitancy is, from your opinion?
I think sometimes they don't want the cost to the patient. They're trying to be conservative. They're like, well, we'll just treat so many times and see if we need it. And that can be when they have trauma, that can be dangerous because you could be giving our patient treatment that is a contraindication.
Right.
I get it that you want to be conservative and see if, do we really want to expose our patient to radiation? That's the other topic. So usually they're thinking for the patient cost as well as, radiation, but all of that is just so minimal and the information is just going to be more beneficial and making sure we are also, we're going to be liable for our patient's care. And if we miss something and just should have just taken a simple x-ray, it could have helped our patient as well as our own license, but helping our patient in referring, getting more imaging, and in choosing the right treatment as well.
Exactly. And I would comment on that too, that I don't know exactly off the top of my head what that is, but I think the dose of radiation that you get is very minimal, compared to other things that we are exposed
Is
to. And at the end of the day, if you have to look at what are the guidelines of standard care, right? And if you always have to think that, oh, that'll never happen. Well, yes, it can happen to you where that one case they're going to call you in and you didn't do the appropriate x-rays and you missed something important. And now you're facing a lot more bigger problems. Not only that, but the patient is shortchanged. They could have had the proper referrals out earlier on in their injury, right? And so it's not appropriate to just wing it with especially an acutely injured patient. It's just you have to do what the standard protocols are. It'd be the same as if you went to an MD and you were complaining of fatigue and they didn't do a blood test. Most likely they're going to try and see if there's something underlying, right? Well, this is for chiropractors, this is the underlying that we have to see, including blood tests as well, right? We can see blood tests
yes,
for inflammation. And remember, patients also have multiple things going on at the same time. You might find something that has been there prior to the accident that they had no idea, right? It's not common for people to just go in and get x-rays all the time. Usually what provokes x-rays, right? Dr. Pedley is an accident. It's not usually you go in, or if you have pneumonia, it's typically, right, for
right.
non-physical act. So how often has a patient actually had their spine looked at? Unless they've been a chiropractic specific patient or have had something that provoked an x-ray. And oftentimes, as you know, they're not even getting the appropriate views to see where the injury might be, right? So
Right, absolutely.
x-rays are your friend.
Yeah.
They're
No,
my
they definitely
friend,
are.
right?
Definitely are.
So
And x-rays, I always tell people is x-rays tells the patient's history because there's times where patients will be like, well, you're a chiropractor. You need to know that. I'm like, yes, I need to know there was fusion. Surgical
yeah,
fusion. Or, oh, I forgot that I had surgical, and they didn't really know what they had done. But we take the x-ray, we're like, oh, that would have been nice to know. So
right.
I always say x-rays tells your patient's history. It helps.
Absolutely. And one coach I was talking to is like, before you're going to put any kind of force into the spine, right? You should know what's there. Like you,
Absolutely.
that whole idea of just come on over, let's just adjust you, at the local market and all
Mm,
this nonsense. I mean, I think it devalues, first of all, what we're doing as care providers
yes.
in the physical medicine space. It totally devalues it. You wouldn't see
But
a pain medicine doctor just, injecting at a mall or something. Like it's just unbelievable where some people go.
yeah,
But in
I
the PI,
agree.
yeah, if you want to be in PI, you want to be respected, you want to be an authority as a chiropractor, and you want to have a referral-based practice that, provides for your family of a great lifestyle, you cannot be, you have to just make a decision. What type of professional are you going to be, right? And I always default to, I need to see what's inside the patient before I treat them because who knows what I could find. I mean, you could find cancer, you could find all kinds of
Yes.
things that are pain comes from lots of things. And sometimes the chiropractor is the one that finds the life-saving diagnosis that they go in and get treated for. And you would have known had you not done these x-rays. It just makes sense to
Absolutely.
me. So
Yeah, absolutely.
if
Yeah,
we're
there's a lot
looking
of
at people,
congenital anomalies out there too that are contraindications to our treatment,
that's
and
right.
we need to know that. We need to know that. We need that information.
Until we have x-ray goggles, we need to take x-rays. Okay.
Right. Exactly.
All
Exactly.
right. Well, thank you so much, Dr. Pedley. This has been
Thank
amazing.
you.
I hope this helps our MedLinks members and also those that subscribe to the channel to keep learning more and ask questions. And feel free to leave comments. We're also going to put down below how you can reach Dr. Pedley, how you can see about becoming a MedLinks member if you want to get in with the elite crew of personal injury as a provider. And have a great rest of your day. And again, thank you so much.
Yeah. Thank you.